Dear friends, the transesophageal echocardiography has a central role to play in Mitra Clip procedures. Before the Mitra Clip, one should be very sure about the severity of mitral regurgitation and the mechanism of mitral regurgitation. The Mitra Clip can address either the Carpentier type 2 or the secondary mitral regurgitations. So in the Carpentier type 2, where there is a prolapse, what we measure is the Flail Gap, which should be less than 10, and the PML length, which should be more than 10 millimeter, and there should be no calcification at the grasping site. So also we have to measure the flail width by either a 3D or by a transgastric view, which should be less than 15 millimeters. For a secondary mitral regurgitation, the regurgitation jet should originate at A2P2 region, and the mitral wall area should be more than 4 square centimeters. The flail, the coaptation depth should be at least less than 11 millimeters, and also the coaptation length, that is the overlap between AML and PML, should be more than 2 millimeters. The very ideal anatomy for mitral clip is it should be a non-rheumatic heart disease patient, no infective endocarditis. The leak should be at A2P2. It should be at least grade 3 and more. It should be a single dominant central jet. There should be no calcium at the grasping site. The non-tethered PML length should be more than 10 millimeters. The flail width should be less than 15 millimeter. Flail gap should be less than 10 millimeter. The mitral wall area should be more than 4 square centimeters. The baseline mitral wall mean gradient should be less than 3 mm of Hg. The coaptation depth in secondary MR should be less than 11 millimeter. The coaptation length, that is the overlap in secondary MR, should be more than 2 millimeters. The LV cavity size should be less than 65 millimeter, and the trans-septal crossing height should be more than 4 centimeter from the mitral annulus. So in the Intra Procedure transesophageal echo, you needed to define the leaflet target, to look at the trans-septal puncture and guide it, self-steering of the steerable guide catheter in the LA, and aligning the catheter, the clip delivery system, then confirming the leaflet capture during the grasp, assessment of MR reduction after the clip is released, and exclusion of significant mitral stenosis, and then assessing the intra septal shunt. So this is how the leaflet target is decided. It should be a single jet specifically from A2P2 region. One uses a bicable view and a perpendicular view for targeting and guiding the intra septal puncture. So the septal puncture should be posterior and superior. So the thing is, the antero-posterior guidance you get by looking at the short axis view, while the superior-inferior aspect you get in the bicable view. The needle causes stenting in the intra septal, and you know the site at which you want the puncture. So also the puncture site should be at least 4 centimeter above the mitral annulus. So the trans-septal puncture, achieving it correctly, is half the battle won. So there should be sharp tenting in both the views. It should be slightly superiorly and posteriorly. It should be at least 4 to 4.5 centimeter above the mitral annulus. For a very deeper coaptation, less than 4 centimeter may be acceptable, or if the flail leaflet is going all the way in the LA, then more than 4.5 centimeter may be desirable. Then the steerable guide catheter is advanced over a stiff wire into the left atrium. It should not be more than 2 centimeter inside the left atrium. Now you have no clue on the fluoro how much you have entered the left atrium. So this steerable guide catheter is very well seen on the transesophageal echo, and it should not be more than 2 centimeters inside the left atrium from the septal puncture. One can see that in 3-dimensional view also. Once you have, this is a steerable guide catheter and this is the pigtail to measure the left atrial pressure. Then maneuvering the steerable guide catheter and the clip delivery system is a major role of transesophageal echo, because this steerable guide catheter, it should be turned in such a way that the clip delivery system moves towards the mitral wall without touching the free wall of the left atrium. It should not damage the Coumadin groove or the or any free wall of the left atrium, because that can tear the left atrium. So following the path of the clip delivery system by transesophageal echo is very important. So you should not reach the left atrial free wall, and you should steer free of the free wall towards the mitral leaflet, and this should be done continuously in the biplane view of the left atrium. Now, once you are closer to the wall, one can take the 120-135 degree view to get the anteroposterior orientation of the clip delivery system. Generally, you have a biplane viewing where the second image is 45 to 60 degree view, and that gives you an orientation of either medial rotation or the lateral rotation of the clip delivery system. So that is how you should have continuous biplane monitoring, where the primary image is a bicommissural view for the medial and lateral orientation of the clip delivery system, and the second view should be the 120 degrees long axis view for the anterior posterior orientation of the clip delivery system. So in this particular patient, you can see that the clip delivery system is exactly on A2 P2, and this you can see in the bicommissural view, and also you can look in the long axis view that it is towards the center of the valve. While here you can see that the clip delivery system is medially towards the A3P3. Now in this particular patient, you can see that the clip delivery system is more lateral towards the A1P1, and in the long axis view, it is in the center of the mitral leaflet. Then you have to open the clip in the left atrium and not in the left ventricle. You have to first open it in the left atrium so that you know the orientation of this clip vis-a-vis the AML and PML. And for that, one should know that your clip delivery system is going through the center of the jet, and then you align it by 3D echocardiography. 3D echocardiography is mandatory to know that your clip is perfectly oriented perpendicular to the coaptation line of AML and PML, and exactly at the desired scallop. So this is so the 3D is absolutely mandatory, and you have to toggle between the 2D and 3D while the procedure is being done. So like this, in patient, you can see that the clip is quite rotated, and it has to be rotated clockwise to make it perfectly perpendicular to the AML and PML coaptation line. So we can see that successfully the clip is being rotated, that finally now it is perpendicular to the AML and PML coaptation line. Then the clip is closed and then advanced across the mitral wall into the left ventricle. In the left ventricle, the clip is again open. Now you should not maneuver or rotate it inside the LV, otherwise you will damage the chordae. Once the clip is opened in the LV, you have to again judge that the clip is perfectly perpendicular to the coaptation line or not. For that, you reduce the gain of your 3D data set so that you can visualize the clip in the LV. Now here you can see that the clip is not oriented inside the LV correctly. While in this patient, you can see that the clip is perfectly oriented. After you have reduced the gains, removed the leaflets, you can see the clip inside the LV, and you can see that it is perfectly well oriented. Once the clip is well oriented, you open up the clip arms and pull it towards the LA and try to grasp the leaflets. For that, you use the long axis view, where you can look at the AML and PML lapping inside the clip arms. While you are pulling the clip towards the left atrium, see that both the leaflets are caught by the clip arms. This is seen when both the leaflets are lapping inside the clip arms. Once they are in the clip arms, you lower the grippers so that the leaflets become taut inside the clip. Okay. And once you know that the leaflets are perfectly taut inside the clip and both the leaflets are inserted inside the clip arms, then you close the clip arms. Once you have closed the clip arms, like this, as you see it on the fluoro, you check for the residual mitral regurgitation. Now here you can see that there's a very trivial mitral regurgitation remaining across the clip, which is perfectly acceptable. For this, now you rotate through all the way from 0 to 120 degrees to check for any residual MR jet. The next best thing is to look at the pulmonary vein flow. Now in this patient, one can see that before the clip, the pulmonary vein flow was only in diastole and there was complete systolic blunting. The moment the clip was delivered, you can see that there is a nice tall systolic forward flow and also diastolic forward flow. So now you have got a continuous systolo-diastolic flow in the pulmonary vein, telling you that the LA pressures have dropped and the MR is significantly reduced. Then one can again look at the 3D. This is before the clip deployment and this is after the clip deployment. Before the clip deployment, you can see there's a large jet going towards the intra septum, while after the clip is closed, you can see there's a very small trivial jet which is in the center of the leaflet, which is acceptable. Then you look at the mitral wall gradient and see to it that it has not increased. You can also look at the LVOT velocity time integral to see that the forward cardiac output has increased. Then you look at the intra septum for the residual shunt because of the trans-septal puncture and passage of the steerable guide catheter. As you can see that here, there is a much larger intra septal gap is seen, and this needs to be closed by the ASD device. Then you look at the 3D to see the central bridge of the clip, and there are certain criteria for the device success, that the MR grade should be less than 2, the gradient should be less than 5, the wall area should be above 1.5, LVOT gradient should be less than 20. This is how the transesophageal echo performs the most central role in mitral clip